All right, guys, we're back on talking drugs here, and this one's one that you're not going to see too often. When you do see it, though, you need to know about it, know how to use it, which is sodium nitroprusside, and it definitely has uses, and you're probably going to see this more in a hospital-to-hospital transfer if you were to do one. And again, let's talk about what it does and some of the things about this drug you got to make sure that you do and you know. It's also known as a nipride drip or a nitropruss, and notice how I said nipride drip because that's how we give this one. We give this IV drip form. We don't push the old nitroprusside. Well, you can push it, but the good news is you'll be doing something else. Usually it has something to do with CPR afterwards. So again, it's used to treat congestive heart failure and life-threatening high blood pressure. It's a non-nitrate. Again, it's an anti-anginal. It helps to dilate the coronary arteries, so that's why a lot of people. That's why they like to use it, especially up in your ICUs and when you're dealing with heart patients. And again, it's a good antihypertensive. So it relaxes both the arterial and the venous smooth muscle, and a very potent vasodilator, very very potent, and it reduces the preload and afterload. So by dilating out these vessels, again, there's plenty of places for the fluid to go, so the heart's not having to push against the force that's already in the vessels. And then it reduces how much actually comes back into the heart. Again, if you've got a really high preload, this is a good thing. Again, patient that's in congestive heart failure usually has a high amount of preload coming back into the right atrium. They got, usually wedge pressures up around 50 or 60, which of course is really bad. When a wedge pressure is the sensor that actually measures the central venous pressure, central venous pressure goes into that right atrium. And again, it should be around 25, maybe that's the high end. So if you've got really high return to the heart, we can measure it and we can titrate it effectively. Now, I know I just went all critical care on you, so again, how would I know this in the regular patient? They got really big ankles, their blood pressure's up through the roof, their diastolic pressure is really high. These are good examples of when you would see that type of situation. The good news is this stuff works pretty quick. Once you start the drip, 1 to 2 minutes, and then it lasts for about 1 to 10 minutes after you discontinue the IV. And I'm going to say probably around the old 2 minute to 3 minute is actually, usually when you shut this stuff off, it immediately stops it. And this is the problem, because a lot of people say, well, we can just take him off this for the transfer. No, you can't. Okay? The point is this stuff wears off really, really quick. So we need to make sure that we maintain that medication, especially in the transfer setting. It uses the low blood pressure for the emergency and hypertensive. If they've got swelling in the brain, it actually does. It will help that as well. And it decreases in heart failure. And if they've got a certain degree of cardiogenic shock, it will help reduce this. Now, the weird part about this is they usually put them on some sort of pressor as well. So they'll give them something to strengthen the heart as well as reduce the preload and afterload. So usually when this is hanging, they've got other drips running with them. All right, it does increase ICP. It's just like any other vasodilator. It's going to increase everything. It's going to increase the size out there. It's going to lower blood pressure. You can get some ringing in the ears with it. Again, bradycardia can definitely happen with this drug. As a matter of fact, it's usually your clue, when you start seeing them really slow down. Again, nausea, vomiting is kind of the standard. Anytime you're messing with a vasoactive drug, you're probably going to get that. You might get a rash at the site. A thiocyanide toxicity might actually happen because of that, because it does contain some of those. It converts within your body into a form of cyanide. And again, usually you excrete that. It's not a big deal. Again, absolutely, the things, if they have non-cardiac hypotension, if they've got a volume problem, fix the volume problem. If they're a lactating mom, we definitely don't use nipride. And again, relatively as a tobacco intoxication, or if we know that they've got a problem with their liver, we usually stay away from nipride because it's, again, it's metabolized in the liver, not metastasized, metabolized. Again, any type of antihypertensive or violent anesthetics, they add to the hypotensive effect. So it's really going to drop their blood pressure. Matter of fact, they'll usually wean them off the nipride before they get into anesthesia, and then of course when they finish, that's when they'll usually end up putting them back on. You have to further dilute it in D5W before administration. We don't do a direct injection, and by the way, don't use normal saline with it. You really need to use D5, and you need to protect it from light. Usually, this medicine comes packaged with a black bag that goes over it that covers it, and it's usually supplied in the vial, and it needs to be run on a pump. Do not, I repeat, do not, please do not run this by the drip count. You really need a precise measurement of this drug, okay? This one has to be on a pump. If you get there and they go, oh, you can put it on a dial-a-flow. No. All right, the patient needs to have an arterial line for real-time blood measures. Now, everybody at this point is going, well, that makes this a critical care drug. Well, sometimes, you don't get that option. But if you do have to use a non-invasive blood pressure, I would definitely set that thing for every 5 minutes. And the reason, if not sooner, if I have a nipride drip started, guys, I always have an A-line. That's the long and the short. If they don't, if I don't have the means, I take the means with me to monitor that A-line, without a doubt. You need to do that. Again, if that means it has to go by critical care, well, here's your excuse that you can use it. But there are systems out there where you, again, are going to be taking this drip, especially for an emergent setting. So be aware of that. All right, 50 milligrams of 2 mLs usually is diluted into a 250 bag. Most every one of them I've ever seen is you dilute it. You put 50 in 250. And then you run it in at usually, I usually start at 1 mic per kilo per minute, but the range is actually 0.5 up to 10, and I titrate it to my blood pressure. So if I start at 1 and their blood pressure's 200 over 100, and I put it up to 2, and they go to 180 over 100, and I go up to 3, now they're down to 160 over 90. So do it very slowly, and that's why, again, that A line is wonderful, because you can sit there in real time and watch the blood pressure actually go down as you give this. Again, we don't give it to a lactating mom. It can be given to a pregnant female. Based upon the whole lactation thing, I would say probably not a good idea to give it to any type of pregnancy. We can give it via IV, and then I know that it says IV push. That is incorrect. No, that is wrong, okay? That is wrong. We usually give this by drip and drip only, okay? And it can go in the IV, or it can go in a drip, okay? But we do not, and I repeat, it's a no-no. Don't push it. IV drip, IV drip, IV drip. All right, that's it for nitroprusside, and I will see you guys on the next one.